Yeah, actually, as Dr. Mufi said, after medicine, I just practiced only a few years because the reason why I did only for a few years because I was interested in research, but then I also had some unpleasant experience, or rather, we were going through a very bad phase with respect to our lifestyle. My husband was diagnosed with, at the age of 30, 29 onwards, he had hyperlipidemia, LDL was high, and he was pre-diabetic and fatty liver changes with enzyme elevation. So that is the trigger for me to dig deeper into nutrition. Then the kind of experiences I gained or the kind of associations I've done over the years is actually triggered by this kind of an experience. And we did a lifestyle intervention in 2011, 12 time frame, and he was like 110 kgs. I haven't put his picture here, and he was already in the early metabolic disease phase, and once he was even admitted in a cardiac ICU with all lot of issues and panic attacks and stuff, and even for kidney stones that we had to undergo robotic surgery. But the metabolic part of it, disruption, which is dyslipidemia, pre-diabetes, hypertension, and hyperuricemia, which the doctors have put him on medication at the age of 30 or 31. And then that gave us some kind of a perspective change. He's like only 30 and our child was, young. And then we decided, is this what we want to do the rest of our life on medications? That gave us some level of, change in the mindset that let's change our habits and lose some weight. So that from losing weight, we really get into the deeper aspect of nutrition, and we reversed his condition. That time I didn't have much knowledge, but whatever knowledge I gained from reading and understanding, and also through the network I had, especially abroad, help us to reverse all the conditions in 8 to 9 months. He's not on medication even now. He's 40. He's in his mid 40s. No medications. My child is 14. There is no issue. So that is the thing which changed our life to get into something of lifestyle intervention. So let me get into the topic now. Dyslipidemia is one of the common thing which we see in our setup, because in India, though we are not a country which consume large quantities of red meat, we do eat large quantities of high saturated fat rich dairy products in the form of ghee, butter, and paneer and stuff. So and another thing is some of those areas where tropical oils are used. There also we see a higher trend in higher LDL level. And we all know that genetically Indian continent, especially Southeast Asians, we do have a lower level of HDL. So that is very well-known fact actually. So let's get into the details now. Yes. The dyslipidemia, I presume that all of us are doctors, so we all know that is an elevated LDL. One of the most common reason I've already mentioned, higher saturated fat rich food, and hypertriglyceridemia, which is basically this part of it. I have seen a lot of familial component coming in recently, but even then there is a large population which is responding very well to it. And then lower concentration of high density lipoprotein, which is very specific to our genetic or demography. And we all know that 1% rise in total cholesterol lead to 2% rise in cardiac diseases. This is also known to us. Okay. And I think this part is not very visible, but the current lipid guideline says that, I'm just focusing on the non-HDL part right now. So LDL level, what the American Heart Association, American College of Cardiology, all of them says that it is to be kept normal, within normal limits, which is now from 100, it has gone to 70. And for people with comorbidities and also past history of cardiac illness or very strong family history, it's even 55. So the numbers, but we used to do. Like even the guideline came in 2018, we were like focusing on bringing it down to 100 till 2016, 17, or even 18. Even we started doing this recently, maybe 2021. It's very difficult to bring to a level of 70 without a whole food plant-based eating pattern, or many cases we may need statins too. Before getting into the details, this is also for, I presume that most of you have some experience with the lifestyle intervention or have attended seminars and other things from ISLM or similar bodies. So this is something every lifestyle physician should know. Hierarchy of causality of chronic diseases, basically, which we all learn in medicine, but not much focused on that. We look at there are distal causes, medial causes, proximal causes, and risk factors. As modern day physicians, what we were trained is to focus on risk factor mitigation. Basically, when there is high blood pressure, dyslipidemia, hypertriglyceridemia, what we do, we try to reduce the risk by giving medications. It is risk mitigation, which is one of the best strategy available as of now to kind of reduce the chances of an impending cardiac event or a stroke. That is something which is to be done. But now, with the understanding of science over the last, or nutrition, or over the last 10, 15, or 20 years, we do know that we can definitely work a lot on the lifestyle factors, especially the part of nutrition, and not only prevent diseases, but also kind of reverse certain conditions, basically physical inactivity, right nutrition, hours of sleep, all these things can be actually addressed or should be addressed when you come up with a patient who has been diagnosed with this kind of a disease. If you're not addressing this and if you're not able to help that patient, you're taking a huge privilege out of the patient. So when you are guiding a patient to make this lifestyle transformation, you're not only actually helping him to change his weight or lab parameters, you're also helping him to lead an aspirational living where his energy levels are high, his cognitive power is high, he enjoys an optimum health or productivity, well-being. 1 second. Yes. So otherwise, yeah, I think one slide I made. Okay. So currently what we do is, as already mentioned, when there is medicine, there is a condition, we do risk mitigation. Risk mitigation is like the guy who is mopping a floor because the room is flooded with water, but there is a leak tap that is not addressed. So that is something which we need to be focusing on. Actually, we are all intelligent creatures. Medical education is one of the top highly cognitive and highly intense education system in the world. And we are just like trained to mop the floor. We are not trained to do lifestyle intervention. I do agree that lifestyle intervention definitely need a multidisciplinary approach. It's not the way we practice right now, where the patient is coming to you and you just give a medication and just ask the patient to go home and take the medication. It is much more than that, actually. You need to empower the patient to take care of the health. You are creating a leader in your patient to lead his own life in a better way so that he enjoys optimum health. That's not easy. But we need, if we don't create this awareness, we will not have the right tools and resources to practice the same. Once we start making those voices, there will be like more and more industry players like PAN or, similar bodies come forward and give us those tools and resources to practice the same. That's what we want. So yeah, we mentioned already this part of it. Everything we have a medicine, like that's how the medical research has evolved over the last maybe 100 years. So now let me come to the cholesterol part of it. Sorry, I think I missed one slide. It's okay. So what is current science says about hyperlipidemia or dyslipidemia or atherosclerosis management or preventing atherosclerosis. This is what it says. A healthy diet pattern improves dyslipidemia and also ASV, CVD risk factors, actually. So that's very known to us. Combining nutrition intervention with other lifestyle intervention has higher significance. In certain cases, you also need medications actually. So it has an additive effect when a person is on medication. You just putting a person on medication because he's not complying with the recommendation which you provided, or his dyslipidemia has a very strong familial component, still you need to advise him on lifestyle intervention because it has additive effect. Then actually that's a lot of studies have done on the dietitian or nutritionist administered medical nutrition therapy, which is found to be very helpful. But what we need to know is actually the current system, the nutritional guidance is actually separated from the major healthcare system. Actually, the patient comes to you, you give a medication, he goes back home. Very few patients, we have done a survey. It says that less than 20% of the cardiac or general physicians advise their patients to go and meet a nutritionist. So that is one part of the story. Second part of the story is, as clinicians, we should be knowing how to guide our people, not to put them all the time into pharmaceutical agents. If it is needed, definitely, but that need has to be decided after you trying lifestyle intervention. So the primary line of management should be lifestyle intervention. Keeping cholesterol and triglyceride level in a healthy range is key to preventing diseases, cardiac diseases, which not only that, even for other metabolic conditions, which is very known to us. So some of these, this is maybe some of you must have come across this slide or the study. This study is published in, I think, ResearchGate, if I remember correctly. I think I put the link down. Interventions on risk factors it's not risk factors. The cause reduction were more effective in reducing mortality than all drugs and invasive procedures combined. There is proof, but we are not able to do it actually. Why? Because first and foremost, we don't have the skill set to do it or the resources and knowledge to do it. Second is the system itself is made in such a way that the whole food system, the environment is such that people are not able to, or the patient is not able to comply with it for a long time or adhere to it for a long time. So I also, because it is about cholesterol, this is something which you cannot forego. It's a portfolio trial, which I think Dr. Mufi must be knowing. This we learned in our lifestyle medicine exam. It's called portfolio trial. It is published in 2011 or 13. It is an RCT. Normally we say, oh yeah, nutrition studies are all about epidemiological studies, observational studies. We don't have enough RCT. One of the RCTs, which is for a duration of 4 weeks, there were 3 arms. There was a control diet with just low saturated fat diet, nothing else. There was no other restrictions or addition stuff. Then there is portfolio diet. Basically, it is a plant-predominant diet, plant-predominant eating pattern, where people were given with a whole food plant-based eating pattern. Along with that, some specific recommendation, which I'm going to have another slide, basically plant-based, soy fiber without statin. Third arm was actually 20 mg statin. So look at the reading within 4 weeks. You can see that the square, blue square, and the red triangle. The blue square is statin, and the red triangle is actually portfolio diet. There is not much difference. There's no statistically significant difference, whereas only saturated fat restriction didn't produce much reduction in the LDL level. So it also doesn't need, and unlike the popular belief that lifestyle intervention doesn't need a lot of time, especially in cholesterol, what we see is once the person is able to follow 80% of the recommendation which we provide, 30 units reduction of LDL is what we see normally. And also there are non-responders. Actually, I am not able to find out the reason for non-responders yet. We need to really dig deeper. Maybe it could be that familial component is very high, but 80% of the people respond very well. See, this portfolio trial is even significant. Even today, this is a recent trial after 2020 that is post-menopausal women. That also says that 14 to 17% risk reduction in cardiac diseases. So there are a lot, if you can check, even portfolio diet itself, they have tried multiple research. So let's see what they have used in portfolio trial actually. It is very simple. It's a very plant-based type of an eating pattern, which included whole food predominantly, majorly coming from plants. They include a lot of variety of nuts and seeds, viscous or sticky fiber, which is basically, I mean, you must be knowing sticky fiber, the soluble fiber. We used to say soluble fiber, the functional fiber. Basically, that is seen in beans, lentils, chia seeds, and some vegetables like, the sticky, mucinous kind of a thing, which you see in lady's finger, brinjal. All these things contain soluble fiber. Even oats, our oats, normally a cup of oats will have 4.5 to 5 gram fiber. Out of it, 2.8 grams is soluble fiber. So you need to advise them to include cereals or legumes and stuff, even vegetables, containing higher quantities of soluble fiber. Okay, that is one thing. Soluble fiber not only reduces cholesterol, LDL, but also helps in better glucose metabolism. Nuts and seeds. And when you look at nuts and seeds and plant-based protein, both are plant-based proteins only, but nuts, the advantage is, when you're giving nuts, it's actually 1 ounce. If you look at the macros, it is like 11 grams carbohydrate, mostly 8 to 11 grams of carbohydrate. It's a good ratio of carbohydrate to proteins to fat. On top of it, some of the nuts like walnut and seeds like chia, flaxseed is high in omega-3. Omega-3 is something which is very well researched in, cardiac events, preventing cardiac events, and also for hypertriglyceridemia, even a familial condition. So increasing that also helps actually. What we normally guide is, they said 45 grams of nuts or seeds a day, 30 grams in Indian condition, we consider as an ounce. For them, they consider 45 grams a handful actually, which is, 1.5 ounce. Maybe you can say that if it is in 2 tablespoons, 2.5 to 3 tablespoons, 3.5 tablespoons, you can say. So it's better you use the term handful of nuts a day, predominantly walnut, almonds, flax, and chia. And plant-based proteins, this is something even for us, it is very difficult because the eating pattern, what we have is actually a predominantly grain-based eating pattern. Though India doesn't consume large quantities of animal products or, what do you call that, red meat-based products, we consume large quantities of dairy, one part of it, a lot of refined carbohydrate in the form of white sugar, white rice, and white stuff, and a lot of packaged food. So it's something on a practical level, we find it very difficult. 50 grams of plant proteins a day, it's very difficult. But, like in the urban situation, it's very easy because we get a lot of tofu and tempeh soy products here. So that's something which they have used. And plant sterols and stenols, I haven't used any of these supplementation yet. But basically, this is 2 to 2.5 grams is what portfolio trial used actually, majorly coming from squash and soy and many of the herbs and stuff. So it is something which they have used, but I will tell at the end of it what we normally do. Then this is generic guidance. Basically, what all things we do is, like first and foremost, lifestyle intervention. When it comes, we need to address everything. One is a self-awareness pillar, basically making them aware of when they're getting stressed, sad, all those kind of things. Actually, we call it stress management in lifestyle medicine. That is the first thing we should be doing, because stress can not only affect your, sleep and other stuff, it can also affect your choices, the way you live your life, the choices you make with respect to your eating pattern, everything. So that is something which you need to address. Then physical activity, as this part of it also, you must be knowing at least minimum 150 minutes of physical activity a day, adequate sleep, 7 to 8 hours of uninterrupted sleep, and then no alcohol, smoke, those generic recommendation, plus specific dietary recommendation, which includes replacing saturated fat. Saturated fat rich is one of the major reasons. Though portfolio trial says that lower intake of saturated fat is not giving much benefit, but there are a lot of trials which came subsequently. Even AHA came up with some presidential address in 2018. It actually substantiates the point that higher saturated fat intake is leading to higher LDL and atherosclerotic changes. So replacing saturated fat is very important. Some practical aspect for this is basically where is the saturated fat coming from? Basically, in our context, Southeast Asian context, we get it from dairy, whole fat dairy, red meat, basically beef, mutton, lamb. Even chicken has some quantity. Egg yolk has 2 grams, but it's not very large quantity. And then you also get it from tropical oils like coconut oil and coconut oil and palm oil actually. So in Kerala, I have seen a lot of people, especially who are in Middle East. Most of them comes to us with high LDL, that is around 160, 180 range. The sudden thought comes to mind is that is there a genetic component? But it is not a genetic component. It's the high coconut oil usage which is causing it. Trans fat food limiting, which is not, see, whatever recommendation we are talking about, even for dyslipidemia, is something which will apply to most of the metabolic conditions, or also to improve your health span or longevity. So it's not like something very specific. There are very specific things, but generally what we say applies to everything. Limit food containing trans fat. Trans fat is basically coming from hydrogenated oils, cookies, cakes, and those kind of things, creams, even salad dressings, which normally we urban people use in our thing, that and all contains trans fat. The recommendation is 1% of the total calories, but most cases when you're eating even one serving of cookies and cakes, it'll exceed that actually. Even the packaged food contains trans fat. The fried, what do you call that? French fries contain trans fat. So it's better to avoid them or limit them to once or less than once a week. It's something guidance you can give to your people. Replacing saturated fat, again, coming back to that, saturated fat, the total saturated fat, as per American Heart Association, you need to restrict to 5 to 6% of the total calories. That means a person consuming 1,000 calories can have around 60 calories of 60 calories from saturated fat. So 60 by 9, because since it is fat, 60 by 9, it is, how much? 60 by 9 is around 8 grams or saturated, or an average adult, not on calorie restriction, can have around 12 to 13 grams of saturated fat. But the problem is when you are taking a tropical oil, 1 tablespoon of coconut oil, you're already consuming 11 grams of saturated fat from 1 tablespoon of tropical oil, like coconut oil. When you are taking 1 tablespoon of ghee, which is giving 9 grams of saturated fat. So any other food source which gives a little bit saturated fat, your upper limit goes high. So that is something to be careful. So best practical advice in such scenarios is actually eliminate saturated fat containing food regularly from your diet. Okay, if you want to take it like red meat or some stuff, it's advisable, ideal scenario, not to use it. But like people, because of the cultural characteristic and many other things, they want to use it, keep it like a kind of like once a week or once in 10 days or something, so that it doesn't exceed. You cannot always count these numbers by looking at the meal. It's not very easy. So it's better have some guidelines around it. And you also will see the AHA guideline, why saturated fat, replacing it with unsaturated fat is very beneficial for health. You can see with statistics actually. Prioritize fiber-rich food. We already mentioned soluble fiber-rich food, especially the ones which contain soluble fiber or functional fiber. Then, in certain cases, plant stenols and sterols, which we discussed. And there are cases which doctors consider giving omega-3 fats. Even I also have given omega-3 fats to some people who responded very well. But I didn't go beyond 1 gram per day because, there were males, that PSA, prostate cancer, and higher dose of DHA connection. So I just did it with 1 gram. They responded well, but along with they were also following this lifestyle and dietary recommendations. And DPA, the omega-3 which I gave was actually algal omega-3 because they were vegetarians. And also there were like few cases which they were ready to take the supplement from seafood. That also responded well. And EPA, DHA, that level of 1 gram per day, with meeting that with the plant-based one is difficult if you don't plan it very well. Because what are the sources of omega-3? I think I'll discuss that in the next slide when it comes. And we already discussed replace saturated fat with PUFA. Why? It's coming in the next slide. Packaged snacks, replace packaged snacks with the fruits and unsalted nuts. This is something which we always ask people to do. Take out all the packaged food out of your grocery shelf and pack it with fruits, like unsalted nuts, even legumes like roasted chana. Chana is basically Bengal gram, and lentils. Those things actually. Whole fat dairy to be replaced with low fat or plant-based milk. Oil. Definitely this is even olive oil may be useful, or flaxseed oil may be useful. Canola. These kind of things. Not health-wise, it is better, but as per lifestyle medicine, we need to go for whole food, plant-based sources of fat, which are nuts, seeds, and avocado. It was very difficult for me personally to shift to a eating pattern without oil, but now we have trained our cooks to do that. Actually, adding little water helps, and then stir frying the vegetables and things like that. But I don't know whether initially you need to address your people to do to that extent, but at least tell them, for a family of 3, cook with minimal oil for every dish. Not more than 1 tablespoon of oil. That itself will restrict the total oil consumption. Oil consumption to be restricted not only because of it's a processed one, but also actually very high in calorie. 1 tablespoon of oil is 120 calories. Unnecessarily you're stuffing your body with calories. And refined white grains and products. So white grains, this is basically to be restricted because any excess calorie will go and deposited fat. Also, triglyceride level goes high when the calories goes high, not only directly related to fat. And this we discussed, trans fat rich to be restricted, saturated fat to be restricted, processed meat, ultra processed food, packaged food, refined grains, alcohol, food high in sodium. So these needs to be restricted. Food high in sodium, not directly related to your dyslipidemia, but dyslipidemia along with other things, especially if the person is hypertensive, the chances of getting him an impending cardiac event is high. The restriction for sodium is, we all know that 1 teaspoon a day, which is like 5 grams, 4.5 grams or so, or 2000, it gives 2,400 salt is like 1 teaspoon, which is 4.4 to 4.5 grams a day, which gives 2,400 milligrams of sodium. Alcohol, again, alcohol has connection with the triglyceride too. Other lifestyle we already discussed, like just managing nutrition alone is not sufficient. Maybe you will get a short-term benefit, but overall wellness, our physicians, we should be, facilitating our people to lead a very healthy, healthy life, productive, happy, optimize their health. So that needs addressing other areas of lifestyle too. So that is something which you should not be missing when you're doing this guidance. Don't overdo one area, but do everything in balance. Just some knowledge about saturated fat-rich diet. Maybe some of these slides I can share. Saturated fat-rich diet, we always think that only meat has it. Beef has around 6 grams per 100 gram. Lamb has 9 grams per 100 gram. And pork has 5 grams per 100 gram. But look at coconut oil, or the tropical oils actually. It's 47 or 50 grams per 100 gram. I told you 1 tablespoon has around 11 grams. It is so high. So that is something to be restricted or to be taken care. You don't have to completely cut down, but at least have guidelines around it. What we normally do is, if you're using coconut oil, use only 1 teaspoon per meal so that it doesn't exceed the overall number if they're not using any other source of saturated fat. If you're using other sources of saturated fat like whole fat dairy or cheese and other stuff, cut down coconut oil, no coconut oil. Use something which doesn't have much of saturated fat like olive oil or canola, sesame, these kind of things. It all has, per tablespoon has 2.5 grams only. Cheese, 21 grams per 100 gram. Whole fat milk, 4.5 grams per 100 grams. So it just goes, the list goes. Paneer. Paneer is in India, we call paneer. It's cottage cheese. Basically, one of the major things which I notice among the gym goers in India, especially if they're coming from a vegetarian household, they actually try to meet their protein by eating large quantities of paneer, and their saturated fat goes high. And also this gym goers, there is a normal tendency, hey, you need to have higher intake of proteins, and people don't know nutrition. A common man don't know nutrition. They are getting nutrition guidance from the gym goer, and naturally they'll start increasing their saturated fat intake by increasing the paneer. And after 4, 5, 6 months, they'll come to us, oh ma'am, my saturated fat is high. What should I do? I have my family history of this, that, and all. The reason is not the family history. The reason is actually what he consumed. So when I talked about saturated fat, I thought, okay, bringing this AHA presidential address, you can all go through the study, but the link is given below. All prospective observational studies says that, or shows that, this study came in, this result came in 2018 because there are a lot of confusion about around saturated fat. 60, 70 years of research. After the 7-country study, Framingham study, there have been consistent research on saturated fat and connection with this. Cardiac diseases. But there were also like some of these occasional studies on an RCT says that a saturated fat is not the cause for it. So there were a lot of confusion. Even the medical fraternity were like totally confused. Then actually American Heart Association took up a large number of studies. I don't remember, 300 and some studies, and they did a meta-analysis. And this was a brief on that meta-analysis. It says that prospective studies says that when you're replacing your saturated fat with PUFA or MUFA, PUFA, when you're replacing it, reduces CHD risk by 25%. If you're replacing with MUFA, it reduces by 15%. So PUFA, okay, how will you replace saturated fat? Okay, if you're using ghee butter, okay, use it, replace it with a MUFA-rich food. I mean, ideal solution would be eating nuts, seeds, or avocado. That's a whole food sources of fat. You can also replace your ghee in initial phases when somebody is not ready to go off oil with PUFA-rich oils like, some of them I would recommend sunflower or something, but very limited quantity. Again, sunflower, there's a bit of controversy related to the omega-6 content. So again, where to be on the safer side, there are gray areas in nutrition. To be on the safer side, you should tell them, like ideally the best scenario would be going in for whole food for sources of fat. But if you're using oil, limit oil to 1 tablespoon a day per person. So that means 1 teaspoon of oil per meal. So even if it goes a bit high, that's not going to cause him much trouble. So that is something. Euphoric oils, we are already aware, basically 77% of the calories in olive oil is MUFA, and canola also, I think 66 to 70, or even now it's more, I think it is 70 plus 77% or something. So RCT, many RCTs were done, Mediterranean type of the diet in combination with PUFA. Substitution of PUFA, MIFA for SFA has reduced the CVDs. And very specifically, that report has written that coconut oil and dairy fat increases LDL. In many cases, India, we are still not ready to go off the fact that dairy can cause high LDL, because the cultural characteristic, the way we kind of believe dairy is a superfood and stuff. So that's the reason. But science is not saying that actually. Substitution of PUFA causes 25% reduction, which we already discussed. Trans fat increases CBD, which we all know, there's no doubt about it. Omega-3 intake is associated with the reduction in fatal CVDs, actually. But there is one thing. So when you're replacing saturated fat with bufa, it is increased benefit. Even you're replacing your saturated fat rich food, like a paneer with a whole grain food. Okay, it is also good carbohydrate. Coming from something like a legume. Okay, paneer as a protein source is replaced with legume as a protein source, or even a tofu as a protein source. There is 11% reduction. But when you're replacing your saturated fat with refined carbohydrate, which is white rice, white stuff and all, it is not getting any benefit. Rather, it is increasing the risk by 1%. So what you replace with what is very important. It's not just following something blindly, knowing the science very important, and updating these recent development also is very important. Yeah, trans fat rich food. There is not much controversy as of now, because now everything is associated with the trans fat. Trans fat is basically coming from cookies, cakes, fried potatoes, vanaspati. Paneer also contains, ground beef contains, and all these fried chicken, these kind of things. And I think the person who made the slide, my nutritionist Bhavani, forgot to put the cream which we use in salads, dressings and all, that also contains trans fat. Fiber-rich food, this is for better understanding. These are the fibers. She has already put soluble fiber-rich food separately. So fruits normally have around 1.1 gram this thing per serving. The oats, total fiber is 10.3. And it's per 100 gram, I think, if I'm correct. Yes, most of the things are 100 gram. Soluble fiber is 3.8. I told you this actually. This table is very important. See, as when we are starting to practice nutrition, it's not just about giving a guidance as at the patient level, where you ask your people to increase your vegetables, fruits. That's not the way. You need to have these numbers in mind. Soluble fiber, even now I struggle with some of the numbers, but saturated fat, carbohydrate count, proteins, all these come automatically to me because I keep referring them back and forth. So that just registers in my brain. Soluble fiber, I need to still register. But some of these numbers are very important because that calculation comes in automatically in your brain. And actually that when you're guiding the patient with that kind of a calculated approach, it improves the outcome a lot. Omega-3 rich fatty acids, basically for plant-based, is flaxseed, chia seed, hemp seed, some of the vegetables like spinach, avocado also contains, and basically the fish and fish oil supplements. Fish, basically the mackerel, the high-fat fish like mackerel, sardine, salmon, and albacore tuna. These contains high omega-3, which is DHA, animal-based ones, DHA and EPA, dihydroxypentanoic acid, and this thing. And plant-based is called ALA. ALA, but ALA, so when we are taking plant-based omega-3, it ultimately converts to DHA and EPA for the body actually utilizes DPA and DHA for its activities. But ALA normally get converted into DPA and DHA. But there's one thing, if you're planning to turn more plant-based, you need to understand the conversion rate is very low. So higher intake, better this thing. For example, I think flaxseed provide around 1 or almost 2 grams or something, 1.8 or something, but the conversion rate is only 3 to 5%. Okay, so we need, so the conversion rate is much lesser. So hence you need higher intake of these items to get the similar benefit as taking up seafood source of DHA and EPA or omega-3. And whatever recommendation we said, just by cutting down saturated fat, it has some benefit. I'm not saying that it doesn't have benefit. But when you're cutting down your saturated fat, trans fat, refined carbohydrate, plus or salt, sugar, plus adding those high fiber, soluble fiber food with exercises along with that, plant stenols, sterols, when you're combining these things, there's a cumulative effect, addictive effect. It's not like everything is adding to the outcome, actually. So there is a cumulative effect, actually. That's we need to understand. Also, like people, some cases, their LDL doesn't come down with lifestyle intervention, then you start on statin. There are cases which we have done that too, actually, but that cases too, you should not actually just start a statin, just leave them like that. You should ask them to follow lifestyle intervention, because with statin, even with statin, lifestyle intervention has additive effect or cumulative advantage. So I just a case study to reinforce the point. This is some, this is only wife's details I've put in here. There's a couple actually in their 40s, lady came with very high LDL, HbA1c 13 point something, LDL was high, blood cholesterol was high. Husband's case, his dyslipidemia was there. On top of it, his triglyceride was around 1,000 range, actually. So when we took the history, we understood that these couple were on a very high juice, what do you call the Tropicana, something which is available in the market. I think it's available in the global market, Tropicana, and they were drinking that at least 200, 300 grams, cups, servings a day. So once they cut down that, their levels came back to normal. But the triglyceride is one of the major reasons what I found in this couple and few other couples are high fructose intake. But this high fructose intake is not coming from fruits, but coming from juices and high fructose corn syrup. When you're taking fruits, the advantage is fruits also comes along with the soluble fiber and things like that. So it doesn't raise your things as much. So this person was not only on that, she was on higher consumption of high fat dairy, packaged juice, saturated fat was very high. At the same time, fiber, omega-3 and phytonutrients were very low. That is why she was having HbA1c 13, and her, LDL was high, and husband's triglyceride was high. They went on a very good lifestyle intervention. Initially, they were not ready to go off dairy or reduced dairy product, but slowly they kind of reduced everything. And, as lifestyle intervention, we put together a team. There's a nutritionist, there's a lifestyle physician, there's a PA expert, there's a psychologist, all together manage the condition, because lifestyle intervention has to be done in a multidisciplinary approach. Actually, it's always better, but I don't say that the other things doesn't work. And yeah, this is the major reasons they identified. This was a change she brought in initially from a large quantity of refined grain without any legumes, nuts, seeds. And she used to have at 5 servings of dairy a day, whole fat dairy, which she thought fat is going to help her. And then 3 servings of these Tropicana juice a day, Tropicana similar juice a day, and then a lot of fried items. I think they joined in May. August, we took the report. I think between we took the report, but LDL was still high. But when that time, because, she was not ready to go off the whole fat dairy, because she felt that was the source of her calcium and protein. And some of these people know a lot about it because they read here and there, and knowledge is not always, there is a lot of dissonance in the knowledge, the disconnect. So then finally, her HbA1c back to normal, total cholesterol back to normal, triglyceride back to normal. The couple is doing it well, and it's now 1+ years, and still the results are all normal. So what I conclude saying is, whenever somebody comes to you with this kind of a condition, always do lifestyle intervention first and learn about it, how to do it, make guidelines for process for each of these conditions, guide them through that, connect them with the right vendors, if possible, or exercise buddies, stuff. But if it doesn't work, you should not be waiting for too long to start a medication, because medication has its role. Optimal medical therapy is important in certain cases. But as clinicians, we should know when to start medication. That's very important. Yeah, this, I think, this is all. This is just, I put some plates and all for your understanding, I think. Yeah, I think we can have a Q&A session right now. Yeah, how long I took, I think, yeah, I think I took a little longer, sorry. Yes. You're muted.
Oh, sorry. Yeah. It was still very informative. It was great. So we do have quite a lot of questions for you. So maybe if we can just go through them quickly, because I know that you have to leave quite soon.
Yeah.
So just to start with, which lifestyle interventions are recommended in isolated hypertriglyceridemia?
Let's see. The specific isolated hypertriglyceridemia, dyslipidemia, or any genetic component also coming into the picture. Any kind of things, always give a generic recommendation first, like reduce your saturated fat intake, increase your fiber intake, predominantly have whole food plant-based eating pattern. Ideal scenario would be advising the people to fill their half of the plate with the vegetables and fruits, a little protein, which can come predominantly from plant-based sources, but okay to have some things from animal sources too, and shifting to from a refined carbohydrate to whole grain intake. These are the generic recommendations which we can give. But hypertriglyceridemia, I think that can put that slide there actually. Again, yeah, because I put one slide because I just got some time before I went out. Basically, here what we need to understand is from the case history itself, you understood that high fructose intake also, because of the high calories, it can lead to hypertriglyceridemia. But the fructose, there are multiple studies showing that fructose in the form of whole food, fruit sugar, is not causing that kind of high rise in LD triglyceride. So you don't have to restrict. Most doctors think that they have to restrict fruits. They don't have to restrict fruits. Fruits still should be given, but the low fructose fruits with high fiber, the one with high fiber containing fruit. Always when they're taking fruits, advise them to have it with nuts or seeds. Okay, that also helps with overall nutrient value. Then definitely fiber-rich whole grains, which I've already discussed. I also mentioned this, that certain cases I give omega-3 supplementation. 1 gram is something which I normally suggest, not more than that. Fat-free dairy, or in a Bangalore scenario, I change them to a whole fat, to a plant-based milk, or reduce the overall consumption. Because most people, when we ask them to reduce, reduction doesn't happen. They get chance, they overconsume actually. So it's better giving that avoidance works, or giving an alternate source works better. Then sugars. This is something American Heart Association says, that sugar 10% of the total calories. Ideally, it says that 5 to 6 teaspoons of added sugar per day for a woman, 9 teaspoons for man, 100 calories for woman, 150 calories for man. It's better actually. How do you guide that? It's very difficult. So if they're taking beverages, ask them not to use any of the sugar based stuff, and avoid all the packaged food which contains sugar. These are the kind of things. And carbohydrate, I do not limit, because when you're following a plate pattern, like half of the part with the vegetables and fruits and little proteins and carbohydrate, that pattern, when you follow, you're not overloading your body with carbohydrate. Otherwise, what we normally eat is 80% carbohydrate with refined sugar, and there is not much of protein or fat. So I don't think we need to restrict that part of it. Just ask them to follow a whole food plant-based pattern.
Yes. So with that, you've answered the next question. Is there an association of fruits with triglyceride?
Yes, this is what fruits, triglyceride. Since we don't have large data to prove that, what we have data is actually high fructose corn syrup. Fructose coming from fruit juices is definitely causing high triglyceride. And there are a few studies which says that fruit in the form of whole fruit is not causing problem. So what the ideal scenario would be, give a guidance for fruit consumption, 2 to 3 servings a day, not whole day on fruits, or like large quantities of fruit. That's something which you can give. And add the rest of the thing, vegetable, 2 to 3 servings of fruits a day, 4 to 5 servings of vegetables a day, which is like 3 cups. So that itself will solve the issue.
What is the effect of lifestyle interventions on various lipid structures, like LDL, triglyceride, HDL?
Yeah, we already discussed it, triglyceride and LDL, because that's what the major discussion was. HDL, I didn't bring it because we still need data, but some of the things which I can say from my experience and from my knowledge is LDL, there is not much variation happening with only nutrition intervention. Some of the things which is researching, which is showing promising result is physical activity. Okay. High long activities, endurance activities, which is increasing the LDL level. Another one is nuts, especially Brazil nuts and few nuts, which is macadamia and all, actually helping to increase the HDL level. That itself like goes back to the AHA guideline. I didn't put it there. It says that when you are replacing SFA with FUFA from nuts, which also enhances other lipids. Okay, so that is something which I want to say. Otherwise, this is not really giving a lot of, there is not enough research to show that HDL can be improved with nutrition intervention alone, actually. Yes.
How and when would you decide to prescribe statins in a patient following?
Yes, this is a major question which I always have discussions with cardiologists, especially doctor, many of them actually. See, what happens is you should look at the lipid management, that chart. People with risk factors 7.5% and above, I haven't taken statin completely because statin has already proven long-term benefit in reducing mortality. Right? Even if their lipid level is around 55, 56, I haven't taken them off. But a regular person with primary prevention, if his lipids levels are within normal limits, coming down, showing a tendency of coming down while he's on statin, we will start taking it away by 1.5 months, and then do the repeat test after 30 days to see whether it is sustaining. And again, 30 days actually. So once it is sure that it sustains and it's responding well to the lifestyle intervention, we just ask them not to use it. There is a client recently of mine, finally, she didn't want to take medications at all. And I was also not aware of a primary hyperlipidemia genetic component. Then actually 6 months down the line, she has lost weight, her HbA1c back to normal, all the things back, but her LDL level came down only by 20 points, in spite of her not consuming any dairy or, red meat and coconut oil and stuff. Then finally, we had to ask her, you need to consult her. I told her to start statin, but she was not reluctant. Right? She wanted to try with some other alternate stuff. I told her this is the thing, you need to start up. Then I put her to a cardiologist because certain cases, it doesn't respond. It's a strong familial component. Yes.
So you basically just wait to see it coming down and you make a decision.
Yeah, but once it comes down, once the patient comes with patient is on statin and his level is still around 130, 140, observe for lifestyle intervention for 1 month. Just see whether that person is able to follow the lifestyle intervention. Once they are able to follow, you can take a chance. Okay, then actually see whether after a month I normally take down the medication because most of the people are not very high quantity of statin. I am just dose of the statin. Then, like 30 days, you do the test, another 30 days, within 3-4 months, we can decide that it just go off. That happens to a large, normally first 3 months, the person follows lifestyle intervention. Once we take off the medication, there is always a 30 units reduction in LDL that I consistently see actually. So that is something which is very much possible. But also, like as lifestyle physicians, we should not be just thinking that it's the only way out. Lifestyle intervention is not the only way out. There are cases which doesn't respond.
What is the evidence of intermittent fasting and keto diets?
Yeah, I've seen that there are a lot of studies which is coming out. Maybe my logical explanation for this is actually when the insulin level comes back to the baseline, maybe that benefit the overall metabolic pattern. Okay, that is one part of it. So hence the overall thing, overall insulin related pathways is better. The lipidogenesis gets better, more efficient. At the same time, if the intermittent fasting normally comes with calorie restriction, energy restriction. So that itself is an advantage. But if the calorie restriction comes with a high saturated fat containing food, I've gone through, after seeing your report, I've gone through at least the kind of studies I have, which I've collected over the years. I haven't seen anybody specifically mentioning what kind of diet they followed, whether it is saturated fat rich diet or it is trans fat rich diet. So we don't have data. So intermittent fasting as a simple tool, as the only tool to manage dyslipidemia, I do not recommend. Dyslipidemia has to be managed with a portfolio type of diet and other lifestyle interventions.
Have you seen anything otherwise with keto?
Yes, of course. Keto.
That's a hot topic.
Yes, yeah. A lot of keto people goes through this keto dietary pattern and comes to us with a high LDL. And, some of the other things I've noticed is high inflammatory, this thing, CRP goes high, and some allergic things, many of those things. That's why they're coming to it. They have already lost weight and their insulin level gets better and stuff. So when they come, what I understand is actually when they are shifting to the keto pattern, they are actually like only thinking about restricting the carbohydrate. Okay, because carbohydrate is a major thing. I just did a video about protein mania. I put that in our group. So what happens is then they are focusing only on that increasing the fat percentage to a particular level. When that is only focused, when the fat goes high, most of the fat which they are using is saturated fat. So LDL goes very high. So that's a very common thing. Even if they want to go ahead with a lower intake of carbohydrate or grains, it is still possible with healthier fat increase, like nuts, seeds, avocado, those kind of things. It is still possible because they still believe that, that kind of a dietary pattern helping them. It is not keto anymore, but it is lower grain consumption is something which we do. And the keto in long term, you must have seen that also AHA and ACC has done an analysis. So that is, they are also saying that long-term sustenance of this is not something advisable. Also, long-term sustenance is not possible. That is something. And second one is when people are following keto, there is a advantage people notice, because that's why people get attracted to it. When you're cutting down the carbohydrate initially, the grain portion initially, that is why when you're cutting down, naturally your liver glycogen goes down. Once your liver glycogen goes down by 1 grams, it also takes out another 1.5 grams of water along with it. People see sudden reduction in weight. Like in a week's time, they see a 2.5 kg, 2.5 gram kg reduction. So naturally people get carried away. And on top of it, keto is a highly restrictive diet. It gives better weight loss. Short term, I do not have a problem if they take care of their saturated fat intake. But long term, or trans fat, I've seen a lot of them using butter also. Long term, I would recommend a healthier, well-balanced eating pattern with predominantly vegetables, fruits, grains, and legumes.
How do you manage lean dyslipidemia with lifestyle?
I think there is not much difference between lean and this thing, because the lifestyle intervention, when we do, only thing what we need to take care is a lean person should not again become lean, lose weight further when you are, because most of these interventions, when they do it, a whole food plant-based eating pattern automatically brings in a calorie restriction. So calorie restriction comes, weight loss comes. So we normally use AHA's guideline. Replace your saturated fat with the PUFA rich food. That is mostly higher calories. So they will not lose weight actually. So that helps also. Overall cardiac benefit also happens actually.
Then can you recommend some good oil? So with this also they've asked, is soybean oil better? Is mustard oil better?
This I was very clear in my presentation. I think as doctors, we need to start shifting to whole food sources. of fat. Okay, that is the first thing. If you're using oil, limit oil to 1 tablespoon per person per day. That means 1 teaspoon per meal, something I recommend. And if you still want to lose oil, use oil. Soybean oil is good, canola, olive oil. Personally, what I use is I use olive oil in salads because my husband and family, my daughter and all likes it actually. So I use olive oil for salads. Cooking, I stopped using oil, at least for me and my this thing. My people, the people working my house use it. They use sunflower oil and all. Soybean oil is okay. Canola oil is okay. Sunflower again, omega-6 rich. But again, when there is a gray area, try and limit the usage and go for whole food sources. Okay.
What's your advice on using coconut milk?
I didn't get that question. So it was
on using coconut milk. I think because you're from Kerala and we use a lot of coconut milk here in Sri Lanka.
Yes. Yeah. I mean, I know. Actually, like coconut oil is a killer, okay, in larger quantities. Coconut oil, I've already mentioned, 1 tablespoon has 11 grams. And maybe skin and other things, you definitely can use it for very small quantity, you can use it. But coconut milk, when it comes to milk, using maybe a few tablespoons, 4 or 5 tablespoons a day is not going to cause much harm. We practically recommend Kerala people is 2 tablespoons because they cannot live. I mean, I myself is from Kerala, but I don't use much coconut. I kind of used to like an urban Bangalore kind of an eating, that too with a whole food thing right now. Yesterday we had aubergine grilled and tofu, this thing. That's the kind of things we eat over the last many years because the kind of issues we faced made us to lead that kind of a life. But with Kerala people, we take 2 tablespoons of grated coconut per person, maybe 4 or 5 tablespoons of coconut oil, coconut milk. That's what we recommend. But most of the time that number doesn't work. Finally, we'll have to ask them, cut down your coconut. You start stir frying the vegetables like this, use herbal seasonings instead of salt. All these things we do because that's restricting what my practical experience is. Most cases, some of these areas where they're staple, there's kind of a coconut oil is a major this thing for them. That will not work. It's better to cut down or give alternate choices.
But so they comply better when you ask them to avoid? I mean, from your experience.
Coconut oil, I always ask them to shift to olive oil or canola is what I do. But I still feel that people still use it. Then some of them restrict to 1 teaspoon. But actually, you need to see where the client is. Actually, sometimes they only like the smell of coconut oil. So just ask them to brush the pan with a little oil so that they get the smell, but not pour oil. These are some practical things you give, which they don't know normally. They don't think about it. And some, actually, I've used a lot. I've seen a lot of foreign clients. They started using that kind of I don't remember the name of the spray. There's a sprayer where they spray with oil so that it just comes as droplets. Doesn't even count to 1 teaspoon. So that also helps actually.
So the last question, what is the importance of the cholesterol to HDL ratio?
Yes, okay. There's again a very hugely controversial thing. Non-HDL is okay. But the recent study or whatever discussions I have with a few of the eminent people in the field, what I understand is total cholesterol to HDL has predictive value when it comes to an impending cardiac or stroke and those kind of things. But non-HDL intervention, that part of it, like LDL and VLDL, has higher impact when it comes to the outcome of cardiac event. So this is how I put across. So predictive value, total cholesterol to LDLC has, HDLC has, but when you are intervening, the LDL or the non-HDL has higher significance. Why that is also known? Because LDL intervention is easier, it's well known. We know that over 60 years of research. We still do not have data or strong data how we can improve HDL. So that could be the reason. Predictive value, total cholesterol to HDL, and intervention or related stuff, non-LDL. Non-HDL, that means LDL, yes.